So thank you to allow me to speak to you today on the discontinuation of the renal replacement therapy in our ICU patient. So as you understand, we've got a lot of data on the initiation of kidney support in our ICU patient with a large number of randomized controlled data published in a high-level paper with sometimes opposite results. But from this data, we could draw easily algorithm to help us at the bedside to define the best way to initiate renal support in our ICU patient. And we would like to have the same thing to stop the renal support in our ICU. However, when we take a look on the literature to help us in this way, we are quite disappointed because over the last 20 decades on initiation of renal support, we can count around 200 papers, whereas for discontinuation of renal support, we got only 50 papers with low level of accuracy, with retrospective data in a small group of patients, and so it's very easy to find an answer to our questions. However, it's a real problem because we know that our renal support can induce by itself damage on our kidneys. It has been well reported, for example, in this review, where others describe that our kidney can be submitted to three main problems. Firstly, to an hemodynamic impact of kidney support, particularly because we've got intravascular volume depletion, decreased cardiac output, altered regional blood flow, or systemic hypotension. We can have also inflammation problem, particularly by activation of cellular mediators, activation of humoral mediators, activation of cytokines, which have been well observed in the situation of extracorporeal support. And finally, we could have also a toxic effect directly in relation with the several solutes that we can use for kidney support in this way. And so we would like to stop very quickly this kidney support. Indeed, but if we do that, we can expose to a failure for the winning of kidney support. And as it has been well observed in this study conducted in ICU patient, comparing winning success with winning failure, we clearly observe that if we have winning failure, we're going to increase the mortality in our ICU patient, and so we're going to have a direct impact on the survival of our patient because we don't stop the kidney support at the best time. And so to find the best time, we need to have an index to help us in this way. The most important index that we could find in the literature is clearly the urinary output. When we take a look on the studies conducted on this way, we are quite disappointed because, as you can observe here, the sensitivity and specificity of all these studies is quite low. And if we take a look on the cutoff, which could be used to stop renal support, is quite large, from nearly 200 milliliter to 2,000 milliliter per day that can be used at the bedside. Moreover, if we take a look on this study, most of the studies are conducted after discontinuation of renal support. And at the bedside, we would like to know before discontinuation if we can do this discontinuation. And if we take a look on the literature, the study that use this index, in reality, we've got very few data. And one more time, the range is quite large to define the best time to stop renal support in our ICU patient according to a volume of urinary output. So this parameter seems not to be a good one to help us at the bedside. And what we would like to know is the potential recovery of our kidney. And so we could imagine to use test to test the kidney, the nephron reserve, and the kidney recovery. Laseric tests have been proposed in this way, and you know that for initiation of renal support is not a good test to know that, as it has been reported before. But for the discontinuation, it seems not to be a good one also. Several studies have been conducted on this way, and if we take a look on the ROC curve, for example, to define if for the winning furosemide test could be interesting, you can clearly observe that with or without use of furosemide, we got the same result for definition of winning success. Moreover, if we use a high-level dose of furosemide to try to test the kidney, we could also induce by itself a loss of volume very important that could be potentially deleterious for our kidney. So this test is not a quite good test to have an idea on the recovery of our kidney at the bedside. We can't use this one to support winning success in this way. Could biological marker can help us at the bedside? The most important parameter which have been studied is, of course, the serum creatinine, as you can see, but as observed here, you can see that the sensitivity and specificity of this one is not quite good, because a lot of things can induce a variation of the serum creatinine. Another biological marker is, of course, the concentration of urea in the urinary. And as observed here, you can see that the specificity reported here is not quite interesting. And in the ROC curve, the ROC curve is not good in this way. So dosage alone of creatinine of urea are not good parameters to help us at the bedside. We could expect to have a more functional test, and it could be by the way of the 2 hours creatinine clearance, very easy to use at the bedside. You measure the creatinine in the blood, you measure the creatinine in the urine, and you measure the volume of urinary output, and by this way, you're going to calculate very easy during the 2 hours the creatinine clearance in this way. And as reported here, you can see, as reported on this slide, that the urinary clearance has a significant improvement in the detection of winning success compared to the measurement of creatinine alone in the blood of our patient. So it could be a very interesting parameter, and we use this one at the bedside with a cutoff that has been proposed in the literature around 25 to 35 milliliter per minute. And it could define patients that have a recovery, progressive recovery on kidney function, easy to measure at the bedside. Another question is to know if the new biological marker, particularly NGAL or cystatin, could give us new elements to help us for definition of winning success of kidney support. Several studies have been conducted in this way, and you know that for initiation, experts decided to not propose this biological marker for initiation on kidney support. Unfortunately, for the discontinuation, it seems to be equal. It means that if you compare, for example, NGAL and creatinine in ICU patient, you clearly observe that there's no difference in the area under the curve on the two parameters here. We could potentially define subpopulation of patients that could have potential beneficial effect to use this NGAL at the bedside. It could be non-septic patient, but it was described in only one study as reported in this slide. In reality, you can see that if you use a cystatin C or NGAL, the probability to define the good time, the good winning time, is not quite good, as you can observe here on these ROC curves. So all these data describe that parameters clinical parameters, biological parameters, new biological parameters are not good parameters to help us alone, use alone to define the best time winning for our patient for kidney support. What is the solution? The solution is probably to improve the capacity of detection by association of several parameters. It has been indeed proposed in several studies as reported here, and as you can clearly observe here, you increase significantly the capacity for detection of winning success in our ICU patients. Several propositions have been realized in the literature, and for example, this parameter, when you use the urinary urea and the urinary output, you can clearly define a subgroup of patients that are going to have a success in the winning of kidney support. And when you compare the ROC curves, you clearly demonstrate, as clearly demonstrated in this paper, that this new parameter named the daily urinary urea excretion, associating the urea and the urinary output, can improve significantly the detection for winning success after kidney support. Another parameter that could be used is also the association of urinary output at an angle. And when we compare to each parameter alone, you clearly observe significant increase in the detection of winning success in our ICU patient. So to conclude my presentation, I would like to say that the renal replacement therapy stop timing is as important as the start timing. Unfortunately, we've got very few data in the literature to help us to have a good definition of the best time. Clinical criteria are not very effective. Old and new school biomarkers are inconclusive actually, and probably the future is probably to moving towards a combination of parameters to help us to define the best time for stop the kidney support in our ICU patient. I'd like to thank you.